Peter Nash reporting from Eular, Vienna 2024 for Room Now. One of the topics of interest, it's a big debate. Grappa's had a huge project in it. The Axial study is trying to define whether axial involvement in PSA is different to axial SPA with a psoriatic rash. They're putting a huge amount of effort into trying to differentiate the two. From my point of view, they are two aspects of the same disease. I call it Nash type 1 and Nash type 2. If you're sitting in a clinic that is a back pain AS clinic, you see the first phenotype, bilateral sacroiliitis, high percentage B27 positive, symmetrical, typical AS, and 9% of those people have a psoriasis rash. So you'll think it's just axSpA with a rash. If you sit in a peripheral arthritis clinic like I do, you see a very different phenotype, so-called phenotype type 2. Asymmetrical sacroiliitis, asymmetrical syndesmophytes, half, if you're lucky, are B27 positive, a lot of cervical involvement. Of course they're the same disease, but they're two phenotypic expressions of the same disease, and they'll both respond to therapy. They'll have different symptomatology, and they'll have different imaging and genetic background. It's like leprosy. Is it granulomatous? Is it lepromatous? It's still leprosy. It's still axial involvement, and it's splitting hairs whether it's axial PSA or axSpA with a rash. Two of the same disease, just two different phenotypes. Treatment implications are not going to be that different. You treat symptoms and you treat inflammation that you can see on imaging, and I think we'll find that, what are we going to do, call PSA dactylitis different to axSpA dactylitis? Are we going to call PSA enthesitis different to axSpA enthesitis? So I think this will come down to splitting hairs that won't make a huge treatment difference. Thanks for your attention.